Good time, everybody. Today we are talking about chronic pelvic pain. Chronic pelvic pain is a debilitating symptom among women. It affects their quality of life. It has a major impact on health-related quality of life, work productivity, and healthcare utilization. As we know, if you have chronic pelvic pain or any chronic pain, it affects your quality of life and work also. This woman would be less productive than other women. The Royal College of Obstetricians and Gynecologists, RCOG, has defined chronic pelvic pain as either intermittent or constant pain in the lower abdomen or pelvis. It should be at least 6 months in duration and not occurring exclusively with menstruation or intercourse and not associated with pregnancy. So it should be at least 6 months in duration, not occurring exclusively with menstruation or intercourse, and especially not during pregnancy. What about its incidence? Chronic pelvic pain presents in primary care as frequently as migraine, asthma, low back pain. So that's to say it accounts about 20% of all outpatient appointments. So it's a frequent complaint. Estimation of prevalence vary widely, but are thought to be about between 10 and 20%. What about the etiology? In contrast to acute pelvic pain, there is often more than one underlying cause of contributing to chronic pelvic pain. So there will be mix of symptoms. In acute pelvic pain, the underlying cause is single cause. It may be due to ectopic pregnancy, acute PID, but usually in chronic pelvic pain, there's multiple etiology. There may be chronic PID, and there will be also psychological issue mixed with psychological issue, maybe urological problem and with psychological issue. The experience of pain is affected by physical, psychological, and social factors. What are the causes of chronic pelvic pain? Could be due either gynecological, gastrointestinal cause, urological cause, could be due musculoskeletal causes. And the gynecological causes could be due to endometriosis, adenomyosis, or could be due to adhesion, including chronic PID, or could be due uterine fibroids, ovarian cyst. All these may lead to chronic pelvic pain. If there is torsion in the ovarian cyst, it leads to acute pelvic pain. But sometimes there is persistent cyst. This will lead to chronic pelvic pain. Central and peripheral nervous system. Change in both afferent and efferent nerve pathway in the central and peripheral nervous system modifying pain perception. It changes the way we perceive pain. For example, in visceral hyperalgesia and in neuropathic pain. Gastrointestinal cause could be due to irritable bowel syndrome. Irritable bowel syndrome, as we say, there is also constipation, and usually it is different from other causes. Gynecological cause of chronic pelvic pain, usually irritable bowel syndrome, is relieved by defecation. Could be due to constipation, could be due to inflammatory bowel disease, could be due to gluten insensitivity or gluten sensitivity celiac disease. Urological cause. Bladder pain syndrome consists of pain, pressure, or discomfort related to the bladder, but should be at least one other urinary symptom, not pain alone. Should be accompanied by other symptoms such as urgency, frequency, dysuria, in the absence of any other pathology. Or other urological cause may be due to recurrent urinary tract infection or urinary tract calculi. Stones also may lead to chronic pelvic pain. Musculoskeletal. Pain arising from the joints or from damage to the muscle in the abdominal wall or in the pelvic floor. Any damage to the muscle in the abdominal wall, such as sometimes due to surgery, such as cesarean section, or damage to the pelvic floor due to degenerative joint disease. All these can lead to chronic pelvic pain. Also, nerve interruptment. Nerve interruptment within the scar tissue, fascia, or a neuroforamen. It may result in pain and dysfunction in the distribution of the nerve, which is usually highly localized, and it is exacerbated by particular movement. It will be localized. The patient will mention that the pain in only certain area and exacerbated by particular movements such as abduction, adduction of the thigh. Psychological and social issue. Depression, anxiety, sleep disorder. Some of the sleep disorder also lead to chronic pelvic pain. And vice versa, these are also common with chronic pelvic pain. The female, if there is a pathology, chronic pelvic pain is due to pathology such as endometriosis, these lead to sleep disorder. On the other side, also psychological cause lead to chronic pelvic pain without underlying pathology. It may be chronic, so it may be a consequence rather than a cause of the pain, the depression, anxiety, okay? Also, physical and sexual abuse also may lead to chronic pelvic pain. What about the diagnosis? Two important points in the diagnosis is a history and examination. History, a thorough history should include questions about the pattern of the pain associated with the other problem. Pattern, location, exacerbation, relieving factor, type of the pain. Also, if there is any association factors such as psychological, bladder, and bowel symptom, and the effect of movement and posture on the pain. After we take a thorough history, we go to examination. Abdominal and pelvic examination should look for area of tenderness. If there is any tenderness, do I feel there is a pelvic mass, as well as if there is prolapse of pelvic organ, there is distortion of the pelvic organ, there is immobility of the organ due to adhesion. All these will be we will find it in the examination. What about the investigation? Finding from the history and examination will indicate the need for further testing. So, chronic pelvic pain refractory to medical treatment or associated with abnormal examination or finding, if there is enlargement, tenderness, there is irregularity, fixing of the pelvic structure, all of this will indicate that we need further investigation. There is mostly there is underlying cause or there is underlying pathology. So after examination, when we suspect there is other pathology, we have to do further investigation. Transvaginal examination, transvaginal ultrasound, is the least invasive and is the first line method for imaging the pelvis. It's very helpful, but diagnostic laparoscopy is the most invasive test for evaluating the female pelvis, but it has been regarded as the gold standard investigation for chronic pelvic pain. So sometimes when we do thorough history and we do examination and we cannot reach to a diagnosis, and also sometimes the transvaginal ultrasound will be helpful, and sometimes we don't reach to any clue. We have to do, in these cases, diagnostic laparoscopy, especially if the female has chronic pelvic pain for many months or for more than few months duration. However, depending on the preceding workup, 40% of diagnostic laparoscopy fail to show any cause for the chronic pelvic pain. If we see structural, we do diagnostic laparoscopy, we say diagnostic. But if we see any structural pathology during the laparoscopy, we should be ready or we should be efficient to do to surgically treat this problem at the same time. Investigation. What are the investigations that help us in the diagnosis? In case in all sexual active women, we have to keep in mind chronic pelvic pain may be due to sexual transmitted disease. So we should offer them screening for sexual transmitted disease, chlamydia and gonococcus. Pelvic ultrasound, if we suspect pelvic mass by examination, adnexal mass, it will help us in the diagnosis. We can see ovarian cysts such as endometrioma, hydrosalpinx, or if there is tubo-ovarian abscess. Also, it helps us in uterine pathology such as adenomyosis, fibroid. What about MRI? MRI, it helps us in further assessment of pelvic masses or suspected deep infiltrating endometriosis. It also helps us to further characterize mass seen on ultrasound. We see a mass in ultrasound, but we are not sure whether this mass it is mostly benign, malignant. MRI will help us in further assess this mass. Also, it help us in deep infiltrated endometriosis or rectovaginal endometriosis. What about laparoscopy? Laparoscopy, where pelvic masses, endometriosis, or adhesion are suspected, we do laparoscopy. Or if we didn't reach clue in all these further investigation, we can do laparoscopy. Now we will talk about the management. As we said before, there is multifactorial nature. So, this multifactorial nature of the chronic pelvic pain should be discussed and explored with the patient from the start. General health advice is very important. It's include the importance. We have to discuss this with the patient. The importance of diet, hydration, exercise, and sexual health. All these advice should be given to the patient. Analgesics such as non-steroidal anti-inflammatory drugs, opiates, and paracetamol can be prescribed to control the pain. Where clinical examination and ultrasound are normal, we do clinical examination. I didn't suspect any mass, I didn't suspect any adhesion, and there is no any localized pain. and the ultrasound also normal. Women with chronic pelvic pain, we can offer her a therapeutic trial before going to more invasive investigations such as such as laparoscopy. It is invasive. So we can offer her a therapeutic trial using hormonal treatment to suppress what? To suppress ovarian function for a period of 3 to 6 months before having diagnostic laparoscopy. Okay? Hormonal treatment may include what? Combined oral contraceptive pills or the local levonorgestrel intrauterine system, which is progesterone, or gonadotropin releasing hormone analog. Surgical pathology, so the structural pathology, can be treated surgically. Usually, if there is structural pathology, should be treated surgically, usually by laparoscopy, removal of adnexial mass, treating of endometriosis, adenolysis. So, if by ultrasound and examination we didn't see any pathology and the pain is not so severe, we can give her therapeutic trial for 3 to 6 months to see if she improves. If no improvement, we can go to laparoscopy, but by ultrasound there is a pathology, by examination ultrasound there is a pathology, such as we suspect that there is deep endometriosis, or we suspect there is adnexial mass, and this is confirmed by ultrasound. These should be treated surgically, usually by laparoscopy. If the nature of the chronic pelvic pain is thought to be primarily non-gynecological, then what we have to do? We refer her. We refer to the relevant healthcare professional. So we either refer her, I suspect that the woman had irritable bowel syndrome. So I refer her to gastroenterologist, or she has urgency, frequency, dysuria. I refer her to urologist, genitourinary medicine physician, or physiotherapist, psychologist, or psychosexual counselor. All these, if I suspect she has a history of sexual abuse, I can refer her to psychosexual counselor. If despite the above intervention, pain is not adequately controlled, consideration should be given. We refer her to a pain management team or a specialized pelvic pain clinic. As you see from the picture here, this is a case of endometriosis. These black spots, these are endometriotic spot. This is on the fallopian tube, and this is on the broad ligament. These may lead to chronic pelvic pain. In this picture, this is advanced case of endometriosis. As we said, there is black spots, brownish spot, red spots, all these, and there is also immobility of the uterus and tethering of the uterus, and this lead to, and there's adhesions between the ovaries to the uterus. All these lead to chronic pelvic pain. In this picture, there is hydrosalpinx. The fallopian tube are inflamed and dilated, and this dilatation and inflammation lead to chronic pelvic pain. Usually these are surgically removed. In this picture, this is also done by laparoscopy. We see there is a big ovarian mass and they are trying to remove it. If it is benign, we will try to remove the mass alone. If it is malignant, we usually remove the ovary, and we do staging as we do for any ovarian cancer.